Okay, so the first chapter that we're going to be looking at today, and you're going to need your PowerPoint open if you're going to be following along with this, is going to be on the importance of health assessment. Okay, health assessment is very important because it does a lot of different things for us. Okay, health assessment in itself brings us to see a full view of the patient, their problems, and how we can better help them. Okay. The first thing that we are going to be looking at here is our objectives. Is we want to know why health assessment is important. Okay. We want to know what is the foundational step in making a plan of care, which is very similar to the plan. Actually, it is the plan in our SOAP notes. Okay, after we have gotten our subjective history, we've gotten our data, and we have decided on what the problem is. We need to come up with a plan of care. There are 5 core competencies that demonstrate effective response to the needs of our patient. Okay, so we'll need to be able to identify those. We want to know what the components of health assessment are. We are going to be learning how to differentiate between a sign and a symptom. Okay, understanding what primary and secondary source data is. Believe me, we actually deal with that, in the military too. You don't think we do, but we do. Okay, we want to be looking at documentation. Documentation is very important. Documentation is vital, and we're going to explore why that is. We are going to be looking at the different types of health assessment. There are different types. It's not just our head-to-toe assessment and our focused care that we do. We're going to look at our clinical judgments and how we analyze and interpret the data that we have collected. Okay. We're going to be looking at how we have 2 very different viewpoints from the novice medic and the experienced medic, and how they make judgment calls, how they decide what's next, and what steps to take. Some of you may have noticed how the experienced medics will look at a patient and they'll be, nope, we're going to go a little deeper, that's just not, nope, more, nope, okay, good, yep, okay, and we already pretty much know what's going to happen, or what the next steps are, how it's going to go from the plan of care and any sort of follow-up care. Okay, there are 4 components of clinical judgment that we will look at, and it will actually help you, the novice medic or the new medic, to develop that critical care, that critical thinking. And finally, we're going to look at health promotion, health protection. There are 2 very different things, but they are correlated and they supplement each other, and they are things that we do. They are 2 very important things that we do in our practice as medics. However, they are not followed through with very often, and that's a problem. That is a problem. As medics, we need to be out there telling them how they can, we need to be teaching them how they can avoid a heat injury, how they can avoid, getting, rashes from the, the poison ivy and all that, and how to identify what it is, and a bug bite versus, a boil or something. You know what I mean? Okay. And we're also going to be looking at the 3 levels of health promotion. Okay. And what they mean, what they stand for, and how they implement our practices as well. Okay. So what is health assessment? Health assessment refers to, basically, it's a systematic method of how we collect and analyze data. Okay. And its purpose is for planning patient-centered care. Okay. Some of you may not know what patient-centered care is, and that's not your fault. that's, probably partially our own fault as senior medics or, experienced medics, because we just know what's going to happen or what we need to do, and then we don't include the patient. But patient-centered care involves the patient, okay? It involves educating the patient. It involves encouraging health promotion. It involves encouraging health protection, teaching them what they can do to avoid the situation that they're in again for next time. I mean, generally, if a person rolls around in a bunch of poison ivy and they get a humongous rash all over their body, probably not going to be doing that again. However, it's still our job to be teaching them. It's still our job to be showing them what they need to be. It's no different than CLS training, guys. It is no different than showing them how to put in an NCD. It's no different than showing them how to wrap a wound. It's no, these are all very basic things that we can enforce upon them to get them to follow through to avoid this sort of situation. Okay. Health assessment is important because it gives, like I said earlier, the medic a full view of the patient's current health status. Okay. Now, what do we do with that? Okay. Well, clearly, it should go without saying that once we have that full picture, once we have all of our data, we know the signs and symptoms, we know the chief complaint, we've done our assessments, our head-to-toe assessments, we've gone through and done our exam, started developing a plan in our mind. We haven't written it down yet, but we've gone through those things. What this whole thing is, okay, is it is a comparison between what we see there and an ideal state of health. Now, that's going to change a bit, and this comes with practice, but it changes when we have to take into consideration the patient's age, the weight, even their culture. Okay, we have a lot of, maybe not a lot, but we do have some African American soldiers in our ranks. We also have some Puerto Rican and Hispanic cultured people. Yes, I know that most of our ranks right now are pretty much Caucasian in nature, or is Caucasian, but it takes time. It takes a little bit of understanding to realize and notice some of the special considerations for people of different ethnicity. Okay. We also want to take in their psychological and their physiological status as well. The foundational step for all of this is assessment. I would like you to just take a couple minutes to, you can pause the video because I'm just going to keep going, but you can pause the video and think about this. Why is assessment a foundational step? Okay? The 5 core competencies is patient-centered care, work in interdisciplinary teams. This one here, we don't typically use a lot. However, if you deploy, like when we were in Kuwait, we did use interdisciplinary teams. They weren't attached to us. They weren't part of our main body or anything like that. But they were part of like the TMC. We would send people to the TMC to get x-rays, to have labs done, to have certain procedures done that we couldn't do there, etc. So this is the idea about in our regards. That is how we would do interdisciplinary teamwork. Okay. The next one is the use of evidence-based practice. Evidence-based practice is your friend. Trust me on this. Okay. Evidence-based practice is it's exactly what it sounds like. Doing things that are based off of evidence. A lot of the times, we will have the situation where we just do things because we've done them that way forever. That's the wrong answer. Because sometimes we've come to find out that that particular practice is not good. It's not conducive to healing. It's not helpful for the patient overall. And it doesn't help us as providers either. or as people who, as healthcare, I shouldn't say providers because it makes us sound like, doctors and things, but as people who do provide healthcare services, which is what we do, we need to be up to date on those things. We need to know, that standard precautions are very important and that they are, should be utilized for all patients, not just, not just here and there, okay? The next one is going to be applying quality improvements. This goes off of evidence-based practice. We improve our practice from the evidence that we find, the research that we do. And this doesn't just refer to what we do in medicine. It refers to a lot of things, actually. And the quickest example that I can think of is when we're at the aid station. Excuse me, when we're at the aid station and we know it's going to rain. Well, what do? We put up extra walls. We build like a trench around the aid station to keep the water out. We're always checking our radios. We're checking to make sure that we're doing radio checks to make sure that we're in communication with the TOC and the other units, etc. These are quality improvements. They improve our healthcare standard. They improve how we do things. They improve and benefit the bigger picture. Okay, so you're kind of seeing how that these play out here. 3 and 4, they are like this. Okay, they are interlaced very closely. And the 5th core competency, which we don't use a lot unless we've been deployed, like when we used the Alta-T and the the little handheld thing, which was Alta-T, I guess. But the use of informatics. I would very much like to see, I know it's not conducive to, like last year we didn't have the access to the internet for, if we came across a patient with a unique condition, we just had our books in front of us. Now, I know that the major had his phone and stuff out there too, but I would like to see, that we could find some way. I mean, if the TOC can have an internet source out there, I mean, we should at least have some sort of access to maybe like, WebMD or something. I mean, I know that we'd have to put some sort of stipulation on there where, it's only used for medical purposes or whatever have you, but it's one of those things that it'd be important to take into consideration. The use of informatics isn't also just, those things as well. It's using for research. It's using to put in the an electronic health record, an EHR, which we actually do use if we use Alta-T. Okay, so the 5 core competencies actually came out from the Institute of Medicine. Okay, and that's just not Institute of Medicine. It's the nursing side, it's the provider side, it's all of it. Okay? Gathering history. We collect data in our subjective section of the notes. So if we look at our SOAP note, SOAP, S refers to subjective. It is our subjective section. This is where we start to gather our data. Okay? As part of this, we are collecting our signs and symptoms. With this mostly is our symptoms. Okay, there is a difference between a sign and a symptom. If you answered the sign as things that we see, vomiting and stuff like that, you're right. The symptoms of something, what the patient tells you. I feel nauseous. I feel like I'm sick. I have pain in and they point to their stomach. Stuff like that. Okay. Now, medics can collect 2 types of data. Okay, we do, and those 2 are our primary source and our secondary source. Okay. Primary source, this is data collected directly from the patient, the things that they tell you. Okay, we do have secondary source. I have seen it a couple times where especially females will, have, how they have to bring a battle buddy with them, right? Well, they will, the patient herself will be telling something, and then sometimes the battle buddy will say something in that's pertinent for once to the situation. Okay, you can use secondary source information, but you have to note that it is secondary source information. The physical exam. Our physical exam is done in our objective portion of the note. So SO, we get down to O, it's our objective portion. It's our head-to-toe assessment, our vital signs. The signs that we see, okay? The patient turns and coughs and has a productive cough because they, cough out a bunch of sputum, okay? That's a sign. That's something you see. That is something that you would note. And then you would get further in depth with that as well. However, we're just looking at the broad side of this thing here. Here we collect all the data that we can see, and we include the signs and symptoms of the chief complaint. Mostly the signs, okay? Not so much the symptoms, okay? That is because the symptoms are subjective data, okay? Think to yourself of what some examples of signs are. We talked a little bit about them already. Now, the importance of documentation. The number one reason, friends, alright, is you have a legal responsibility to document what you do to somebody. Okay? Now, my greatest of frustrations, and I may have done this once or twice myself, but I catch myself pretty often, and they will turn in a note, because I did a lot of supervising last AT. They will turn in a note, and I'll have supervised the note, or the patient interaction, and I'll go to review the note or look at the note, or because people ask me, how's this note look? I'll be like, yeah, that's good, that's good. Did you write down that you did this? Well, no, I didn't think it. Great, start over, rewrite, because you have a legal responsibility to that. You need to write down everything that you do. Reason being, if something happens and you say you did it, or you did do it, but you didn't write down, it didn't happen. So, if you don't write it down, it didn't happen. You give out ibuprofen, and, they come back, oh, so-and-so gave me ibuprofen, and then you wrote it in, you didn't write it in there, you didn't do it. So, I guess, in case that was a med error, that I guess that wouldn't be so terrible, but point is, just write it all down. Even if it doesn't seem pertinent, it's a part of the patient interaction. You have a legal responsibility. Those little soap notes, okay, those notes that are written, they end up becoming part of the record, okay? The whole point of those is that in case they need to do a line of duty, or the state boards need to look at it and need to make a decision regarding someone's medical retirement, okay, they can go back to the very first time that they met, or that they got health care for that issue, okay, and they can see what was done, anything that exasperated, was the exams done correctly, etc. So that's why it's very important when we are doing our notes, we are documenting everything, carefully. We don't have to be, writing out big long sentences, but we can make our documentation clear and concise and descriptive enough, as the next bullet says, to get our point across. Okay. Now, other reasons is that other team members can use this information. I touched on this, I think it was in the introduction video, or even earlier in this one. Other team members can use the information that you gather. You guys at the line units, be thorough with what you write down. You can go all the way through SO and A and P. Okay, you can go all the way through and write a complete note out. All you have to do is sign it, draw a line under it, send that note with the patient, and we can start on that next line or whatever. You know what I mean? So this is what I'm saying. Other team members can use that information. We can see what you did, what actions you took to help the situation. We can see what history you got. We can see the history of what happened, etc. So that's another reason why documentation is so very important. You know, I mean, I get really irritated if I have to rewrite a note. So the patient comes in after they see the medic, you know, and then I have to start rewriting things. You know, that bothers me. Because I wasn't there the night before. Okay? I wasn't there to deal with the client or the patient at that time. You were. So I want to know what you did. I want to know what happened that night from your perspective. You know, I don't want to know the patient's perspective. I mean, I will later on, but I don't want to know. I want to know what your perspective is, because your perspective is just as important as the patient's perspective and understanding of things. The other thing here, we just talked about it, not only does it stop me from having to repeat myself, but it keeps the patient from having to repeat themselves as well. Okay? I know that, you know, we're in the Army and, you know, we just, a lot of times we say, suck it up, buttercup, and just start talking. You know what I mean? I get it. But, you know, have a little compassion in the things you do. I hate repeating myself over and over and over again, especially the same story to multiple people. You know, as far as my health goes, it drives me crazy. And I know it probably drives a lot of other people, and then you're just sitting here like, well, goddamn. Don't you people talk to each other? You know? Happily for our patients and the things that we deal with, it's usually, you know, the line medic, the sick home medics, and then our provider, you know. And then after that it, you know, goes on, but I mean, there's still not a lot. You gotta think about some people, right, on the clinical side of things, who probably have to deal with 3, 4, 5 different providers at one time. And it gets really annoying between changing floors, going to different units, etc. If you have to sit and repeat yourself. Okay. And the other reasoning, and I would say it'd be the second most important reasoning, besides you have a legal responsibility to document everything, is that this gives us a baseline evaluation. I talked about this in the other points, so I'm not going to beat it to death here. But the baseline evaluation is what we need. It's like when you get your vitals. Okay, we have to know where they're at. We have to see if they'll be trending to something else. If, you know, it's all very basic here, guys. You just have to look at it. Okay, we need a baseline. We need to know what's happening at that time. Now, they go to sick call. We have to, okay, there's a change in this. There's a change in that. Or even if it's like emergency care, you always get a baseline vitals. Okay? Then once they get to the next echelon of care, we get another set of vitals. And then we watch the trend. The same concept applies to how good our documentation is and the overall assessment of the patient. This next slide here, the comparison of the SOAP note and the nursing process. I have heard it multiple times, even in private conversation, because for some reason people don't think I can't hear them. I mean, I know my hearing's bad, but it's not that bad. Okay, and one of them was, God, none of us are nurses. We don't, you know, why is he teaching us nursing stuff? Well, guess what? Here, right here, SOAP note versus the nursing process. It's pretty much the same. Okay, SOAP notes: subjective, objective, assessment, plan of care. You get your chief complaint. You do your head-to-toe assessment. You assess the whole thing and come up with the outcome of all your data, and then you implement a plan of care. The nursing process is the same. Okay, you do your assessment. Okay, now it just changes a little bit. Really, the only difference is what they have done is they have taken SOAP note and condensed it and made it a little bit shorter. The nursing process, you have your assessment, you gather all your data. Then you make a nursing diagnosis. Okay? You plan your next steps of care. You implement those cares. Okay? And then you set SMART goals for the patient, what you would like to see happen, or what they should achieve while under your care, and then you evaluate at the end how well those implementations worked. Okay, so if you look at all the broad concepts and you kind of see how it all fits in here, it's too easy. Okay, it's very similar. All medicine is pretty much the same, no matter where you go. It doesn't change just overnight. Well, sometimes it might, but... Okay, types of health assessment. We have a couple different types here. We have a comprehensive health assessment, and we kind of deal with this for a lot of the new medics starting out. We do this so we can get them to do the full head-to-toe assessment and get them to get a flow for what they're doing. Okay. The comprehensive health assessment, it's a detailed history and physical examination. That's all it is. And it's done right at the primary care setting upon admission to a hospital or a long-term care facility. We probably won't be doing a whole heck of a lot with this, obviously. However, you will find that if you get really good at health assessment and you get really good at doing the head-to-toe assessment itself, it doesn't take as long as you think it does. Okay, the SOAP note is a little bit more focused. The whole comprehensive head-to-toe assessment is a little bit longer, but if you get good at it, it's very to the point. It gets to become second nature, and it becomes a lot quicker and a lot easier. Problem-based or a focus, this is where we see a lot of what we do. Okay, the problem-based or a focus assessment is like if you get a sprained ankle. Okay, it's due to you use an emergency setting, trauma, ERs, walk-in clinics, stuff like that. A lot, it's focused on what is happening at that particular time. You do get some background history as well, but that's not the focus. You're not focused on how some of that history may be exasperating the current situation. Kind of see what I mean there? Okay, so what you have here is just like it says, problem-based, and it's a focused assessment. The next one is episodic or a follow-up. So we actually deal with this one quite a bit. We will get patients that come in for, I don't know, sprained ankle that are really bad, and we'll be like, hey, come back in the next day, and we will check it again and see if it's going down or if we need to adjust stuff. Okay, that's all the episodic and the follow-up assessment is. Okay, it's just making sure that they're following through with their treatment, making sure the situation isn't getting worse, and if we need to tweak our care, we can do it then. We don't really deal with a shift assessment. This is more in like the hospitals. It's more in the caches and the stuff like that, or whatever they're called, where you will deal with a set of medics will come on at one time, and they'll go through, meet with the patients, see them, and then follow up as needed, and then leave. Or leave at the end of their shift. Then the next ones will come up and follow through. It's a shift-by-shift assessment. Okay. Here you would be the purpose of it is to identify changes that happen from the baseline. So what you're really doing with the shift assessment is you are following up. You are seeing if there's any changes or trends or if the condition or the problem is getting worse as time goes on. Pretty simple. A screening, okay. We actually do these, actually. And what I'd like to see us start doing is kind of like doing a, like a, like a little, oh, what are they called? A clinic where we, get a set of medics together and we do, you know, aside to the PHAs, where we can offer free, where we can offer a blood pressure scan or blood pressure screening, and then implement health promotion and protection. Um, this screening, this involves, early detection basically. It's a short, quick exam. Oh, well, it looks like you have a little bit higher blood pressure today. You might want to get that looked at just a bit, might want to talk to the provider about that, because, you know, high blood pressure leads to a lot of other problems, and we want to, catch it early. You know, you need to adjust your diet. You need to have a more active lifestyle. Do you need to be on blood pressure medication? You wouldn't do the medication part at that point, but you would use your screening to be like, hey, there's a little red flag here. You might want to talk to somebody about that. You know what I mean? So, other ones are like, a glucose screening, blood sugars, stuff like that. So again, the next question here is, which assessments do we work with the most? We kind of already answered that already, but if I were to pick out like 2 or 3 from the list, obviously problem-based focus would be one of them. Screening we do quite a bit, and the follow-up assessments. And by the way, when you're doing PHAs and you notice that a patient has high blood pressure, say something to them to tell the doc. I mean, he's going to look at the paperwork anyways, but still, it's part of your job to recognize those things and to give patient teaching and to kind of get them to be motivated to take care of that. Okay? Now, this is where we're going to get into a lot of our critical thinking. Okay? Now, why cluster data? What does that mean, to cluster data? Well, it simply means that you are taking all your information and you are putting it into, putting it all together. You are looking at it, you are analyzing it, you are taking all the stuff that you got, and you are putting it into a, oh, did I lose my spot? I did, hold on. Okay, you're putting all your stuff together, and you are attempting to begin the organization process with it. And this is something that you need to do when you're taking notes on people and you're working with people. Okay, it's only going to make you better. Now, how can all our data be organized? Well, you can organize it by body system, okay, or you can organize it by broad concepts. And the 2 examples that I give you here are circulatory system, and then that would be like a body system way of looking at it, or impaired respiratory function. That would be more, it wouldn't be used for an emergency that someone can't breathe, obviously, because then you wouldn't even be doing a clinical anything, you'd be doing emergency care. But you can look at different concepts, which you'll start to build on as we progress through these various classes and stuff. Okay. All data needs to be analyzed before a plan of care can be established. So the next thing that I'm going to try and get implemented here as we start working with patients more and more is sitting down with people, or with the new medics and medics in general, and working on analyzing information. Okay, separating what is, I don't want to say needed or not, but I mean what is pertinent, what is not, what is going to be needs to be focused on first. I know it sounds like it's a humongous process, but again, it's really not. If you take the time to look at things, take the time to do it and get good at it, it doesn't take that long. Okay. I do believe that medics, especially the new ones, they need to work on this area. Okay, we need to be analytical with our information that we obtain. We need to be figuring it out and building and using critical thinking skills. And that's one thing that I'm seeing continuously that medics across the board are not using. They're not using critical thinking skills. A lot of the older ones that have been here a while, they do. Okay, the ones that have the most guilt in this area are the newer ones. They expect, it seems almost like a cut and dry, black and white thing. No, it's not. Okay, it takes a little analyzing. It takes a little critical thinking. It's that, okay, well, why is this person's blood pressure so high? Why is the pulse high? What could be causing this fever? Maybe it's the infected cut on their leg or something. You know what I mean? Those are simple analysis and critical thinking, but it just gets better. Trust me. Take the time to do it. This is an image of the clinical judgment process. This is really noticing, interpreting, responding, and reflecting, and putting all of that into the context of the situation that we're working on at that time. Okay. So let's see. So how do these all work? Noticing involves recognizing that a situation is or is not consistent with what the nurse anticipates, or medic, or whatever you want to say, or expect that they will see based on the context of the patient's situation. Okay. So we are looking at the situation. We expect something, but it may or may not be congruent with what's actually happening. Okay. And the guy who came up with this, his name was Tanner something or another. I think that's his last name, but that's not important for this. He describes this process as perceptual grasp of the situation. Okay. So noticing is based on the nurse's expectations associated with multiple variables. Okay. The next step is interpreting, or interpreting data, and this is a process in which the nurse uses patterns of reasoning. This is where we get into our reasoning patterns, our analytics, our intuitive processes towards the situation. Okay. Reflecting is a critical component on the development of a clinical judgment. Okay. Reflecting is, well, we have responding first, but all these situations, all these steps, they can go back and forth. Hence, you see all the arrows, right? The reflecting is a critical component of the developmental judgment, and it differentiates in a couple different ways. Reflection in action and a reflection on the action. The reflection in action is reflecting on past experiences in the midst of another situation, and the reflection on an action is thinking about a situation that has occurred and developing a better understanding of it. And that's important for you guys. Okay? That is very important, actually. You can have past experiences and use them to help you reason your way through certain cases, right? That's great. But what's important too is also after you have worked with a patient, you're sitting down, you're writing out your note and making sure it looks all pretty. Well, fine. Stop, read through it, and reflect on it, on the actions that you took. Why were they important? What rationales do you have? What can you do better next time? It's it's a mini personal quiet AAR. Okay, I know we all hate that thing, but still, it works here. It works here. Okay? And we talked about reflecting. Responding is really pretty obvious here. You respond to a situation. Okay? You respond to what's happening. Now, a judgment call, a clinical judgment call, really simply, it's an interpretation of conclusion about a patient's needs, concerns, health problems, the action taken or not, to use or modify standard approaches, to improve new ones as deemed appropriate by the patient's response. Really simple. To make a long definition short, it's how you're going to interpret the situation and what steps you're going to do, as what you're going to do next. Okay, fine. You're in the middle of step 2, but step 2 is not working, so you have to go back and adjust step 2 to make sure you get to step 3, or you never know. Step 1 may be completely jacked up, so you have to redo, your next 4 steps of something. Okay? So, clinical judgment calls, they're, how you're going to be reacting, or rather, reacting isn't the right word I want to use. Responding is better. Okay? It's how you're going to be responding to changes in the patient's condition. We do it really fast if you are working on the emergency side of things, right? Oh, BP's dropping, they're bleeding again. Well, what's the next step? If your next step was to make sure your tourniquets are on tight and they haven't been moved or opened, that's your next step. Then what do you do after that? Oh, their volume is really low. We probably have to supplement that. Start IV. You know what I mean? So you do it in such a way where everything follows through. Okay? So this is a case study on judgment calls, and this is just going to give you an example here, okay? A 50-year-old man arrives at a walk-in medical clinic. He's reporting a gradual onset of cough over the course of the day. He states that his symptoms began while he was at work. He takes no medications and smokes 1/2 pack of cigarettes a day. That's supposed to be 1. His vital signs and O2 stats are within the normal limits. How would you interpret that? How do you think that the novice medic would interpret something like that, as opposed to the experienced medic to interpret that situation? And that's only using the information given. Okay? Think about that for a second. A novice nurse or a novice medic might be seeing this information. They might just collect it as is. Oh, there's really nothing wrong here. It's within the normal limits. Okay? He has a cough. Well, everyone has a cough. They might look just at the surface of things, okay? But the experienced one, and this is their rationale here, the experienced nurse seeing this patient notices that he is anxious. His skin is pale. He is moist. Although the vital signs data is normal, the nurse recognizes that the respiratory rate and pulse are only borderline. Okay? And it doesn't tell you this in here, but that's my point. Okay, and they continue to go on and on about other things. But I mean, just because, and I've seen this too, where, we will look at a situation and things will just be borderline. Well, okay, there's a lot of, why is it just borderline? Why is it not higher? Why is it not lower? What was the precipitating factors to these situations? Why is the client here? What do they do? Do they smoke a lot? Do they drink a lot, or whatever? Different things play into how we make our judgment calls. A lot of things go into what steps we take in the healthcare process. Okay. So we might be noticing all these different things, but eventually what will happen is if we start to look a little bit deeper and we start to notice those little different things, and we'll get into this when we get into like general impression and vital signs, because there's a whole section that we're going to do on that. But you know, when we start to look at those things, oh, they might be a little pale. Why would they be a little pale? Probably because perfusion. Oh, you know, why would they be, you know, having the certain situations that they're coming across? The point of this here is, it may not have been the greatest explanation, but I think I made my point. Just remember your judgment calls, how you set things up, how you look at a situation. Sometimes we may get into tunnel vision, and we'll focus on one thing, but we forget that the condition is relating to the patient as a whole. Okay. Health promotion and health protection, two very different things, but very important. Health promotion is behavior motivated by the desire to increase well-being and actualize human health potential. Okay. The health protection is behavior motivated by the desire to actively avoid illness, detect it early, maintaining functioning within its constraints. So, what does that mean? That sounds so similar, doesn't it? Well, health promotion has a lot to do with, you know, teaching clients and patients and the soldiers, whatever you want to call them, teaching them that maybe smoking's not all that great, or teaching them that they should probably choose the, you know, the plate of vegetables in a salad instead of the fatty cake. I don't know, anything like that. You know, you're sitting there at PHAs, and they obviously are having some struggle seeing the eye chart. Probably be a good idea to, and they don't wear glasses, mind you, in this situation. Probably be a good idea to say, maybe you should see your eye doctor about that, because you only read a certain amount here, and it looks to me like that could be improved upon. So the health promotion here is a lot of those factors. Now your health protection is saying, okay, well, here you have this condition. Let's try to work within its constraints and maintain that health. Okay. You see this a lot of times with people with cancer. Okay. They're getting all these treatments and the chemo and whatever else. So the goal then is to take care of the patient, but still make their quality of life better while still trying to function with that particular disease. Okay. We do have levels of health promotion, and there are 3 of them. We have primary prevention, which is your protection to prevent an occurrence of a disease. It's your first level, okay? We do this all the time too. Immunizations, nutrition, exercise. They have pollution control on here as an example too, but I don't see many of us sitting here telling the EPA to be better. You know, that's way out there. But primary protection, think about it. Just remember PPP, primary protection, prevention. Okay, protecting from something. Okay. Our secondary prevention, this is all of our screenings and self-exam practices. Early detection of a disease before it becomes symptomatic. Halt the progression of the pathological process. So these screenings are like, teaching males about testicular checks, teaching females about doing a breast check, okay, for cancer lumps. Same with men; they can do it on their testicles. Okay. Colonoscopies, getting those when you reach 50 or whatever it is now. Okay. The last one here is a lot to do. You see it with the health protection aspect of things, minimizing the severity or the disability that the patient has. Okay, giving them the appropriate therapy. So your examples here are like diabetes management, okay, cardiac rehab, hypertension management with medications and nutritional menus that are, you know, specifically set up for people with high blood pressure. Okay. So we just have a couple questions here, a couple review stuff here to go through as well. The 52-year-old male patient is admitted to the hospital with a new diagnosis of rectal cancer. Okay. The medic conducts which type of assessment on his admission? I'll give you a minute to ponder that. If you chose the first answer, you would be correct. A comprehensive assessment. Okay, we don't need, this is not a situation that is problem-based. It's not emergency. Okay, this is not a follow-up. Okay, this is a, he has a new diagnosis, so he's probably going to be in the hospital for a little while until they can figure out what needs to happen next. And this is obviously not going to be a screening assessment because they already know that he has colorectal, that they already know that he has rectal cancer. So your best answer for this one is A. The next one, a formation of a plan of care is initiated with A, analysis of data, B, collection of data, C, clustering of data, or D, identification of assessments. And I put in parentheses diagnoses. If you chose 2, then letter B, that is the answer you would want. An analysis of the data, that's not right. The collection of the data, that's the formation for the plan of care. We have all our data together. We start there. We do our assessment, which is our collection of that data. There we go. That's what I wanted to say. It's getting a little late here, so forgive me if I'm a little scattered. But so the idea behind this question is, we know that we're going to be starting to we need to do a plan of care. We need to know how we're going to treat the patient. We're not going to be doing an analysis right away. We're not going to be clustering data because that's what we're going to do after we have collected the data. And we're not going to be identifying anything because we don't know what we're looking at. Okay, so collection of data or assessment is the best answer. During an interview with the medic, the medic learns that a patient has a 5-year-old history, that's what HX is, of hypertension. Okay, which health promotion intervention is most appropriate at this time? This is an easy one. A, teaching the patient how to relieve stress to prevent hypertension. B, monitoring and minimizing the progression of hypertension. Or C, establishing a screening schedule for detection of hypertension. Or D, advising the patient on the benefits of exercise to lower blood pressure. Your best answer is going to be B, monitoring and minimizing the progression of hypertension. We already know that the patient has had hypertension for 5 years. It would do us no good to do a screening because we already know that it's there. Okay. A, teaching the patient how to relieve stress to prevent hypertension. That's going to be the keyword in that one is prevent. Okay, we already know that he has it, so that's what cancels out letter A. Okay. You eventually would teach them, hey, you have hypertension. Let's learn how to relieve some stress. Okay? There you go. That's what would make, it appropriate, but that's not what we're looking at. And then D, advising the patient on the benefits of exercise to lower blood pressure. That's going to be a bit more of a health promotion thing. Or not health promotion, but it's going to be more of a later on aspect. That's what you're going to be, hey, this is what we're working on here. It's pretty similar to the letter A. Okay? A and D are more, we already know that this situation is happening. We would teach these things now to protect the health of the person. Okay? To work within those constraints. The next one, a patient reports painful urination times 2 days. The urine is pink tinged and cloudy. What type of data does this information represent? A, subjective data. B, objective data. C, both subjective and objective data. Or D, secondary source data. And I will admit, when I did this one in the book, I got a little confused on it. Because when I first heard it, I was thinking, the patient is reporting da-da-da-da-da. You know, the patient reports the urination. I know that that's going to be subjective. Okay? When I first heard it and read it, and you probably thought this too, is, maybe it's the patient reporting pink tinged and cloudy. No. I found out later it's you observed this. Okay? So therefore, it would be C, objective and subjective data. Okay? So it's one of those questions where you don't want to read. I found out you don't want to read too much into. You just want to take it for what it says. Patient reports this. I notice this. I know that it's subjective and objective data. And the last question is, which process does the clustering of data facilitate? A, analyzing data. B, collecting data. C, implementing care. Or D, evaluating care. And the best answer for this one is A, because we talked about that earlier, where we need to get a good view of the patient's problem. So we cluster our information, we separate it into either body systems or concepts, or we try to organize that data a bit, and we do that which allows us to begin the analyzing process of our data. And this one you can do on your own. Give you a little thought here. It's the case study for Sharon. She's a 42-year-old woman admitted to the hospital with a diagnosis of acute cholecystitis. I'll leave you to be the one to look up that, because I know you probably don't know what that is. She tells the nurse the pain she's experiencing in her right upper abdomen feels like a knife, and it goes all the way to her shoulder. She is also very nauseated. She tells the nurse that she is exhausted and has not slept for 3 nights because the pain keeps her awake. The nurse observes dark circles under Sharon's eyes. Her vital signs are 132/90, a heart rate of 104, respiratory of 22, and a temperature of 101.8 degrees Fahrenheit. A CBC, which is a complete blood count, reveals that Sharon has an elevated white blood count. Okay? She lies in her bed in a fetal position and tells the nurse that she hurts too much to get up and move. The only 2 questions that I want you to use with this case study is I would like you to list the subjective data and list the objective data. Pretty simple. Okay? And I'm sure you know what all those things are, so you should be able to figure that one out on your own. Okay? I hope you enjoyed or sat down and took this, and we should have a new one coming for you soon. Oh wow, only an hour. That's pretty good. 59 minutes. Not bad. That's one hour less you had to listen to me.